All right. Welcome, everyone. Good to see you all. Thank you so much for taking the time out of your Thursday here to join us for our reports and updates, Disentangling Mental Health and Criminal Justice monthly meeting. This month, we'll have a presentation by Executive Director at Aspen Hope Center, Michelle Muething. If it's your first time with us, thank you so much for joining. If not, welcome back. Essentially, we'll just give Michelle the floor, and following her presentation, we'll offer some time for just some questions and feedback. Feel free to write in the chat throughout her presentation if anything comes up while she's talking. Just with that, I'll go ahead and pass it over to Michelle. Thank you so much for joining us this afternoon, Michelle.
Thanks, Adam. Let me see if I can figure out how to do my screen share. Right. I think when I do this, I will no longer be able to see. So feel free to pause or jump in, Adam, if can you see the whole screen with all my little notes and everything and people, or just the slides? What do you see?
It looks like I can see the slides and the notes. If you have any notes in there,
okay.
I think we would be able to see that.
I'm going to do a different screen share. So it's easier to I have two screens and sometimes I toggle between. All right, I'm going to try this, and this. From start. Now, can you see just the slides?
Yes.
Perfect. Okay. Fantastic. Wow. This is super cool. I have multiple screens. I can get so much more accomplished in the course of a day. Okay. Thank you for having me, Adam. I deeply appreciate it. I'm just going to talk for a few minutes about the Aspen Hope Center and who we are and where we came from. And I've got about 15 minutes, so I condensed my typical hour-long conversation of everything about us into really quick bullet points. But basically, we are a freestanding crisis center. We started in 2010, and we were the product of a gap analysis that was done by the university. Depression Center came out, sent several researchers for about 9 months, and this gap analysis produced 50 recommendations on how to fill the gaps and improve the mental health services in our valley. And this is kind of where we came from. And we started with 4 pillars of service, but our specialty was in crisis. We are not an all-encompassing outpatient mental health center. We're a nonprofit, and our specialty is crisis. And we cover the continuum of crisis from prevention to recovery. So we have education and outreach, our response, our intervention, our stabilization, and then one of the things we are known for the most is our follow-up. We just don't want people to fall through the cracks. The 4 pillars of service we started with are right here. We opened a 24-hour crisis line when we started in 2010. Again, flashback. 2010, there was no state hotline. There was no crisis line in our area except for a paging system that was in place. So one of the recommendations was you need immediate access to someone so they can have help when they need it. And it needs to be a human being on the other end of the phone. So we started a crisis line. Our crisis line is answered by our clinicians, and they are also the mobile crisis clinicians that go out if that triage is deemed necessary. So that's our front end. The next recommendation we latched onto was there was no education and outreach in the community except really for professionals. And we wanted to reach the lay people. So we have a huge arm of service that is education. And then our fourth pillar we felt very strongly about was our communications with our partners. Our community partners are huge. We are the center hub of a wheel, and we are only as good as the resources throughout the spokes that we can refer to. Most mental health centers, if you walk through the front door, you enter the system of that mental health center. You get their case manager, their care navigator, their IOP group, their psychiatrist, their therapist. When you enter the front door of the Hope Center, you get the plethora of resources within our community that are not under our umbrella. They are the specialty centers that our community holds. So that's where we started in 2010. In 2011, we realized the two major phone call trees we were getting calls from were law enforcement and EMS and our schools. And so in 2011, I met with most of our dispatch and law enforcement officers, and we created the first co-response team in Colorado. And we started going on scene with our first responders. We then put together a school-based program. And in 2011, as we were researching, there wasn't a whole lot out there that was evidence-based. So we did the best we could to put a program together based on the evidence we could find. And it has built and compounded from there. We've gone from 4 clinicians in 4 schools to 12 clinicians in 12 schools, fully funded. So again, when we began in 2010, our 24-hour Hope line was answered 24 hours a day, 7 days a week, and calls could come in from anybody. And the clinician triaged whether this could be handled over the phone or if we could respond or should respond in person. So we follow the guidelines of a call center as well as a mobile crisis center. The other thing that we started was I am trained in the incident management system, and Pitkin County, when we opened, had no victims advocates in their sheriff's department. So we became the fatality response in the community. So our crisis clinicians also know how to be crisis managers on scene of a fatality. And we probably respond to anywhere from 30 to 50 fatalities a year in our footprint, where we end up managing the crisis scene so your first responders can do their jobs. I threw in a couple statistics here just to add, but we get about 1,200 calls a year in our little footprint, and our footprint covers Aspen to Parachute, and 31.5% of our total crisis evaluations are moderate to high risk individuals that are coming through our door. I'm going to talk briefly about our stabilization program, but about 30% of those individuals we see, we put in a stabilization program that is an alternative to hospitalization, because our goal is to keep people out of the inpatient facilities. So 30% are stabilized here in our community versus 9% who we hospitalize, and that's an average over 12 years. 32% of our services go to individuals under the age of 18. And I think one of the most astounding statistics that we've all noticed in the last year or so, we had a 137% increase in crisis responses to children 11 years and younger solely in 2021. So that's a huge increase in our little kiddos being in crisis. Our stabilization program came out of a recommendation from the university. They said, you are too rural to rely on inpatient facilities. Aspen is one way in, one way out, 6 months of the year. We have to go over Vail Pass to get to Denver and through the canyon to get to Grand Junction. So we started a stabilization program that is basically a wraparound program that is an alternative to inpatient. Individuals start therapy within 24 hours of their crisis assessment. And they have wraparound services between the crisis clinicians, the therapists who are stabilization therapists. They are not doing your typical long-term therapy. They are stabilizing individuals. And they also have connections to resources in the community to problem solve. People don't typically wake up suicidal. They're suicidal because something in their life is going awry. Some social determinant of health is falling apart. Is that finances? Is that housing? What is that? And that's the connection we also pull in. to this program. We average about 50 people a year in this program. For all intensive purposes, these individuals can meet the criteria of an M1 for suicidality, but they have people in their lives willing to wrap them with us. I think the biggest key is there is no cost to this program to individuals. Our clinicians are very CBT, DBT focused, solution focused to get the thoughts out of their head. It comes at no cost, and in 12 years, we have lost no one in this program to suicide. Our model it was unique in 2010. Our goal was to meet people where they were immediately with no barriers. There is not a mound of paperwork at the front desk. We do not ask about insurance as one of our first overriding questions. The goal is to care for the individual and not put barriers between us and them. Stabilizing people in the community was a high priority because we wanted to reduce the number of transports to the Front Range that taxes the systems around us. Law enforcement has to pay for overtime, and ambulances, psych patients are non-reimbursable transports. So our ambulance services are going bankrupt from being a big white taxi to psych patients. So how can we help them? We want to stabilize them here. In the first year of being in operation, our mobile crisis team reduced ED, psychiatric assessments, and transports by 60%. And so it was a big impact that people felt. Over the years, other nonprofits, or not nonprofits, but other mobile crisis teams have popped up. And obviously, crisis has become a main point of the mental health system in the state and across the country. But how are we different? We are a freestanding 501c3. We are not attached to a CMHC or a law enforcement agency or a hospital. We are independent, and that provides us a lot of flexibility. The other thing that I am told pretty frequently that makes us different is the top of the organization, being me, is an LPC in the state, and I go out on crisis calls. So very often I sit around tables with CEOs and program directors, and they're administrators. They might be LCSWs or LPCs, but it's been years since they've actually been on a call or been on the front lines. And I am frequently told by individuals who come into our organization and those around us that one of the things that makes us different is I am an in the trench frontline worker, as well as the CEO at the top. Number one priority we place in our agency is on training. Our clinicians go through a 90-day crisis boot camp when they're hired. Crisis is an important thing, and it's a specialty as far as we are concerned, and we treat it as such. Our community partners are our keys to success. I spend the most of my time in meetings with our community partners, and if it's not a formal meeting to discuss something specific, we're having lunch, we're doing a training, we're dropping in and just checking in, and that means the world to making a program successful. We're also just laser focused on crisis. That's our specialty. So 12 years we've been in operation. We opened in 2010 when there wasn't anything around mobile crisis in the state. In 2017, we were invited over to Eagle County. The Roaring Fork Valley is severed by 3 different counties, and so our footprint covered Pitt and Eagle, Garfield. And in 2017, we were invited over to Eagle County. I met with several folks over there, and about a year later, they slid a check across the table and said, "We're really not kidding. We need mobile crisis." And so in 2018, we opened our first satellite office, and it was the Hope Center of Eagle River Valley. The clinicians went through that boot camp when they were hired. We started crisis and co-response in 2018 in Eagle. And then today, we have helped them stand up that entity, not underneath us anymore, but as their own 501c3. And most people have heard about what's happening in Eagle with EVBH and them taking on the mental health center designation. So crisis is that arm. One of the most fun trips I've taken is back and forth to Summit County, 2018. I was invited into those conversations, met the sheriff over there. Building Hope was standing up, met many from Building Hope. And I learned as much as I think I taught. They asked what we did. and I explained how the Hope Center worked, and I learned a lot about a different rural community. So great relationships were formed over there, and much kind of reciprocal learning took place. 2019, we received the crisis contract from the new designated ASO. 2020, we went into Gunnison County, helped them stand up a mobile crisis team, formulated their mobile crisis services underneath Gunnison Valley Hospital. In 2021, we worked with San Miguel County. We have a database that is solely built from the ground up for crisis only. And we started using that crisis database with others that were asking of it. And we started training other teams around the state. If you haven't noticed already, I believe crisis is a specialty. The Hope Center is a crisis specialty in the world of mental health. Training is vital, understanding how to respond on scene. It is interesting to hear someone say, yeah, I can do a risk assessment. It's really no different being in someone's house versus in an office. It is very, very different. And we understand that difference. We teach a lot about safety. Most clinicians are not hypervigilant and focused on safety in their world because they're in an office with a front desk and they're comfortable. Our turnover rate at the agency is less than 10%. I know the world is going through an extreme workforce shortage. We are very fortunate to have some phenomenal staff, and our turnover is pretty low. What do we see as the future as crisis and mental health? We see mobile crisis exploding. 2 years ago, I posted a crisis position, and there were 4 positions in Denver, according to my Indeed and ZipRecruiter contacts. They said there are 5 positions posted in Denver. I posted a position last November in 2021. There were 2,600 crisis positions posted. With 988 coming, the world of mobile crisis is exploding. So we added a 5th pillar of our service in 2020, doing consulting and training, because if you ask me about substance abuse, I can give you my 5-second spiel of what I know, but ask me about crisis and we can talk about it all day long. It's our bailiwick. So we started doing consulting and training and helping other communities in the state stand up crisis teams and teaching them the nuances of what we've learned. There's no need to reinvent the wheel if you can learn from others' hurdles. We replicated our model and they have been successful. Gunnison and Eagle are so successful with their crisis teams, and we love being attached to them and having that memory of helping them stand up. Training is huge. In 2020, we rolled out a training program. It is an 8-hour day. It's called In the Trenches. And it basically will help train anyone who is supposed to be on scene. When you think about the workforce shortage, part of the workforce shortage is that people are hired for a position and thrown into that position with no training. Therefore, they have no skills with what they're going to do. They have no confidence in the job that they are doing, and they quit. I hired a crisis clinician 3 years ago. His best friend was a firefighter, and he looked at him and said, "Why do you want to be a mobile crisis clinician? They're useless." And my heart dropped. And the reason they were deemed useless is probably because they weren't trained and had no idea what they were doing on scene. And that's sad. So our biggest takeaway is that crisis has blasted to the front of mental health, and particularly in the last 3 years. And it is now recognized as a formal thing in the world of mental health. The problem is every mobile crisis team across the state and across the country is defined differently, and every co-response team is defined differently. And quite frankly, if you get to the core of it, even the word crisis is defined differently depending on where you go. Our workforce is sparse. Your graduate level clinician, most people don't go to graduate school to become mobile crisis clinicians, wear a ballistics vest and carry a radio. They go to graduate school to become therapists. So it's hard to find your graduate level clinicians to do crisis. Finding a bilingual graduate level person is nearly non-existent. The demand is much, much greater than the supply. Hence, many programs are standing up peer and case management programs to try to meet the needs of mobile crisis requests. So the biggest thing I think I can close with here is we know because of our contacts in our region and in our state, there are a lot of teams and a lot of counties around the state that are struggling, and they're trying to be able to meet the demands of mobile crisis. They're trying to understand 988 rolling out. And we have a large amount of mobile crisis experience and have really enjoyed working with other communities. And we are here as a agency in the state, understanding our laws and rules. And if anybody has any questions, any needs, we would love to just make ourselves available. Thank you. Did I do it in 15 minutes, Adam? I did.
I think you made that good time. Does anybody have any questions that they'd like to ask Michelle? I actually have one, Michelle, that I'm curious about. So you mentioned, obviously, you have the partnership with local law enforcement, and I know it can kind of be an interesting dynamic with the clinicians working directly with law enforcement. As far as training, is there any kind of collaborative training that law enforcement is doing with the clinicians?
So our 90-day kind of boot camp that I talked about, a lot of that is with our first responders. So we have contracts with the 4 different fire departments in the area. I am their peer support supervisor, so we do training with them. Every opportunity that we are on scene is a training moment. Our clinicians do ride-alongs and learn about law enforcement. They come and do sit-ins with us. And then that 8-hour day, that in the trenches class, originally that was geared toward clinicians. And over the last 1.5 years of doing that training, I've had law enforcement, EMS peers and caseworkers say, can we attend? Is it something that would be useful? We've brought them in and they have felt it extremely helpful in their world. I just did one in Avon, and 3 of the police officers who walked away said, I feel like I have new tools in my toolbox. So we work really hard at trying to do that cross training, because you're right, mental health and first response are 2 very different worlds, and you're trying to merge 2 very different cultures.
Thank you. Awesome. Sandy, go ahead, please.
Hi, thanks so much, Michelle. We'll have to invite you over to Gilpin County. So my question, my 2 questions are regarding money. So when you work with the jurisdiction, is it them that are getting grants and funding, and then you're doing the consulting, and or do you help with getting grants for the communities? And then my second part is, when they slid the check to you, can you just give us a ballpark, like what it might take to start one in a smaller county?
Yeah, when we started an agency of 4 individuals, it cost about $368,000 to stand up, and that is a 24/7 response program. Most of the co-response or crisis programs in the state are 9 to 5 or 10 to 7 or 10 to 10 or 7 to 7 or any variation of. Ours is a 24/7 response program. And I mean, that was 12 years ago. It would probably be around $400,000 to stand up a program. Secondly, your first question, yes and yes. So we help get grants. I obviously, as a nonprofit director, write grants. So I can help people write grants and get grants. The consulting piece, usually the communities get together as a stakeholder group, and they kind of figure out how much money they might be able to allocate for a 6-month consultation. And we come in and do a community assessment, figure out what the strengths are in the community, who the stakeholders are, and what the possibilities are. So where are your strengths? We do a great SWOT analysis of what the community's like, help get that. The other thing is, if law enforcement can understand how a crisis team, a mobile crisis team, can benefit them, one of the best pieces of a funding source comes from your law enforcement entities. They will funnel money to a crisis team very similarly to the way they funnel it to their comm center, the 911 dispatch center. Every law enforcement entity in a community funnels money to pay for a dispatch center. because they are their dispatcher. They do similar things for us. So every community is different with what funding source they have and what money is available to them. And then we go outside of there for whatever's left over.
Thank you. Yeah, we've had some discussions that's kind of on the back burner, and maybe having met you through this, it'll move it out to a front burner.
You bet. You bet. Yeah, there's a lot of funding available. I get less concerned about getting funding anymore than I do about getting staff. There's money everywhere, but you can hand me $1 million tomorrow. I have to find the staff to pay for the positions, and that's the hardest part.
Any other questions for Michelle? Linda, please.
I just want to chime in and say thanks, Michelle. This has been really good to hear from you. And staffing seems to be the biggest hurdle, for our government and for the mental health centers all around. And I don't know if we need to put more funding into education or try to, if there's some advice you might have on how we can encourage people who are deciding on careers, that this might be something that they want to do. I would love to hear a little bit more about that if you have some good advice for us. Thank you.
Absolutely. No, thank you. So again, as much as I love my agency and I love my little valley and I love Colorado, I feel very, very passionately to help the field itself. And our field, like I said, when people go to graduate school and they go into a clinical counseling or a community counseling or a social work program, their eye is set on being a therapist. And so when, hypothetically, you have 1,000 people graduate in May, of those 1,000, maybe 100 would consider crisis. And of that 100, maybe 5 would go a ballistics vest, a radio, driving a police car. All right, like that's not why people typically go to school. This is now becoming a new thing. And I think I've been involved in 3 different university conversations where universities are starting to think about putting crisis as a track in grad programs. The bottom line, though, the question that everyone is asking is, do you have to be a graduate level clinician to be able to go out on scene and do this work? And the answers are all over the board, from yes to hell no. Like it is crazy the answers people are giving. So and again, when I put the In the Trenches program out there, I got it copywritten. I got CEUs for the graduate level clinicians. And one of the things I had to do was look up the evidence-based research. There is no evidence-based research on mobile crisis. It has never been a thing. So we are now developing the research. Law enforcement has utilized CIT training. CIT was the poor law enforcement's way to go help us learn something about mental health because no one's paying attention to us, yet you're throwing us to the front lines. In the last year, I've been to Kansas, Washington, Minnesota, Nebraska, and Florida, and all over the country, law enforcement is being pulled from the front lines. Mental health is being shoved to the front with zero training, and they're going to get hurt. People are going to get hurt. And so everyone is trying to find a way to meet the needs of mobile crisis. 988 rolls out in July, and there are a great number of communities across our country that are not prepared for this. At least Colorado is well positioned to have a state structured crisis program, but even some of the counties in the state don't have the understanding of how to stand up a crisis team or how to fund it or how to train them or how to sustain it. So even in our own state, I think there are still communities that are struggling. I work with Daniel Darding and Signal out on the Front Range. Our ASO is Rocky. Where is Gilpin County? I'm so embarrassed to ask.
Well, we are about 45 minutes west of Denver, Golden. and where Central City and Blackhawk are, they're in the south end of our county.
Perfect.
And yeah, so it's just a little county with about 6,000 people.
Gotcha.
Most of them live out in the rural areas, so we're really spread out.
Yeah, yeah. So there's a lot of telehealth options, yet when you talk about rural communities, if you look in our crisis protocols, protocol for, responding to a rural community is when you get to your location, pull out your cell phone. Do you have signal? Because you have no lifeline if you don't. So I come from Indianapolis, Chicago, and Tampa Bay. So I moved here 13 years ago with metro knowledge of mobile crisis. So it's been amazing to take that big city metro knowledge and try to convert it to rural protocols. And working with first response, my entire world is first response. My husband's a police officer. He's a tactical medic on a SWAT team. The entire world that I live in is the 911 world. So yes, I think what you're saying is correct. It's hard to get people to understand what is needed and where do you put the money. And some of that money is just a presentation. I have a full-fledged hour presentation that explains what mobile crisis can do to benefit a community. I've gone to many counties and just given that presentation just to spark conversation to say, what does your community want or need, and who's willing to come around the table as a stakeholder and say, I really am going to help spearhead this.
Well, thank you.
Absolutely.
Just to be respectful of time, any final questions for Michelle while we still have her?
I stuck my contact in the chat. If anyone has any questions or wants to reach out kind of offline, please feel free.
All right, well, thank you so much, Michelle, and thank you everybody for taking the time out of your Thursday lunch hour to meet with us and learn a little bit about the Aspen Hope Center. Thank you again, Michelle, for all of the important work you do and for really being a pioneer in co-response in Colorado. It's really amazing.
Thank you.
Guys do is so
Thank you.
important.
Thanks, Michelle.
So we will
Absolutely. Thank you, Adam, for having me. Everyone have a wonderful weekend. Happy St. Patrick's Day.
Yeah.
Take care. Bye-bye.
Bye-bye.